My name's Sophie, and I'm going to tell you about the development of the weight loss drug Rimonabant. In 2004, excitement about Rimonabant was at an all-time high. An experimental wonder drug, Rimonabant, helps you lose weight. There's no other drug like it, one eager article proclaimed. Less than 5 years later, a more somber tone prevailed, as far less optimistic reports like Rimonabant, obituary for a wonder drug, were published. So, what happened? In the United States, 1/3 of adults are obese and 2/3 are overweight. Health complications associated with obesity, like type 2 diabetes and cardiovascular disease, are well documented. Obesity-related diseases cause an estimated 2.5 million deaths per year worldwide. Right now, there are 3 main approaches for treating obesity. Behavioral modification by promoting diet and exercise is inexpensive and non-invasive, but it's also not usually effective. An alternative is bariatric surgery, which can often help people lose quite a bit of weight. However, it's expensive, and there are significant risks of surgical complications and even death. There are only 2 FDA-approved drugs, orlistat and lorcaserin, for the long-term treatment of obesity. Both produce modest weight loss, about 6 to 8 pounds per year, and have some unpleasant side effects, such as fecal incontinence or headache and nausea. People have known about the effects of cannabinoid drugs for centuries. Only recently, however, did scientists discover the human brain's endogenous cannabinoid system. So far, 2 endogenous ligands, anandamide and 2-arachidonoglycerol, and 2 receptor subtypes, CB1 and CB2, have been discovered. CB1 receptors, the target of Rimonabant, are expressed mainly in the brain, but are also found in some peripheral tissues like the stomach and liver. In 1994, Sanofi reported the synthesis and characterization of Rimonabant. Scientists immediately tested the compound in rodents and saw that it had a dose-dependent ability to reduce food intake and body weight in animals. After favorable results in Phase 1 and Phase 2 trials, Sanofi launched 4 large Phase 3 trials. A significant increase in weight loss after 1 year, the primary efficacy endpoint, was observed in the Rimonabant treatment group. Patients on Rimonabant typically lost 11 to 15 pounds more than patients taking a placebo. Rimonabant certainly seemed effective. However, the increased incidence of adverse events in the Rimonabant treatment group was worrying. Some side effects, like nausea and dizziness, were generally transient and minor. More troubling was the high incidence of psychiatric adverse events in the treatment group, with statistically significant increases in anxiety, depression, and suicidal thoughts, even in patients with no history of psychiatric problems. Concerns were also raised that the high dropout rate of greater than 50% in the trials, in addition to the exclusion of patients with any history of depression, could result in the trials underestimating the psychiatric dangers of the drug. Nevertheless, Rimonabant was approved in Europe in 2006. Soon after, warnings were issued against prescribing Rimonabant to patients taking antidepressants. In spite of these precautions, studies show that up to 20% of patients taking Rimonabant were concurrently taking antidepressants. The drug was officially withdrawn in Europe in 2009. In the United States, the FDA never granted approval to Rimonabant due to concerns about suicidality and depression. Rimonabant was a dangerous and expensive failure. At the end of the story of Rimonabant, what lessons can be learned and what next steps should be taken? First, the case illustrates the challenges of developing a first-in-class drug whose target is not fully understood. It's not clear if Rimonabant is effective at promoting weight loss through action on central or peripheral CB1 receptors. If the latter is a major driver of efficacy, a CB1 antagonist or inverse agonist that cannot cross the blood-brain barrier could potentially help patients lose weight without psychiatric side effects. Rimonabant's story also highlights the necessity of identifying potential adverse event profiles before beginning human testing. Research done after the withdrawal of Rimonabant suggested that psychiatric adverse events are likely due to on-target effects. In fact, mice with suppressed CB1 receptor activity have been proposed as a new animal model for depression. If researchers had investigated this before beginning human trials, they might have known which side effects to look out for. Sanofi targeted a broad, potential patient population, which was understandable from a financial perspective. However, by using weight loss as the primary endpoint, Sanofi's strongest evidence was for largely cosmetic benefits, rather than improvement in long-term health outcomes. future drug development programs would likely benefit from choosing to pursue either a short-term weight loss treatment or a long-term therapy intended to reduce mortality due to obesity. Rather than restricting the patient populations post-approval, future studies must be able to better identify those most likely to benefit from treatment. More broadly, future studies would benefit from a better understanding of the heterogeneity of response to CNS drugs. While Rimonabant was ultimately a failure, lessons learned from its development can serve as a cautionary tale, informing future efforts toward the development of safe and effective anti-obesity drugs.